Thank you for joining us today here at Evexia Diagnostics for our webinar presentation regarding the value and importance of CBC testing for you and your patients, presented by Dr. Wayne Sodano. Without further ado, Dr. Sodano.
Hi, this is Dr. Sodano, the Director of Clinical Support and Education at Evexia Diagnostics. Welcome to the Complete Blood Count webinar. The goal of this webinar is to provide you with detailed information about the CBC in order to be a more effective clinician. So let's get started. So the CBC is a standardized test for the evaluation of red blood cells, white blood cells, and platelets. And this test can provide a lot of information to assist in the diagnosis and treatment of many conditions such as anemia, infections, cancer of the blood cells, inflammation, environmental toxin exposure, kidney disease, liver disease, autoimmune diseases, and a host of nutritional deficiencies. So it's important to remember that blood is specialized fluid that's composed of both cellular and non-cellular tissue. And its function is to serve as a transport system that allows for substances to be circulated within the body. The amount of blood in the average adult is about 5 liters with a specific gravity between 1.055 and 1.065 and a narrow pH between 7.3 and 7.4. So here are the components of the CBC. The white blood cell count with a differential, red blood cell count, hemoglobin, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, red blood cell distribution width, platelet count, and mean platelet volume. And remember, collectively, the MCV, MCH, MCHC are known as the RBC indices, and they can assist with the diagnosis of several types of anemia. So let's look a little deeper into these components. And as you know, the red blood cells carry oxygen to the cells and carbon dioxide to the lungs for excretion. There's the hemoglobin, that's that iron-containing molecule that actually carries the oxygen and carbon dioxide. The hematocrit, that's the portion of the blood volume that contains the RBCs. And there's the MCV, that's a calculation that'll give you information about the average size of the RBC. The MCH gives you information about the amount of hemoglobin in an RBC. The MCHC is a measurement of the amount of hemoglobin found within several RBCs. Platelets, as you know, are used for clotting, and white blood cells for immune system response. Here's some additional test considerations to tack on to the CBC. One is the reticulocyte count, and that can be used to evaluate a patient's response to vitamin therapy, follow the progress of bone marrow transplant, or to determine the impact of chemotherapy on hematopoietic function. And I'll be going over the reticulocyte count in detail later in this webinar. Next is the RBC blood smear, and that's going to help evaluate abnormalities in RBC shapes and assess for RBC inclusions. This is a review of the lifespan of the blood cells. Of course, the red blood cells, they live about 120 days. The granulocytes, 4 to 8 hours in circulation, and then 4 to 5 days in the tissue. The monocytes, about 10 to 20 hours in circulation. Remember, monocytes can turn into macrophages and live in the tissues, and they can live there for several months if they're not being used up. Lymphocytes can go from weeks to months, and platelets are replaced every 10 days. So the RBC count, also known as the erythrocyte count, like I said, the average lifespan is about 120 days. Remember, these cells do not contain a nucleus, so they cannot synthesize proteins for cellular repair. But the RBCs possess systems capable of preventing oxidative stress to the hemoglobin molecule. And low membrane concentration of vitamin E, remember vitamin E is an antioxidant, will shorten the lifespan and contribute to anemia. So you want to keep that in mind. Indications and use of the RBC are listed on the slide to evaluate anemia, support other hematologic tests for diagnosing anemia, serial testing in patients with blood loss, assess for other conditions such as polycythemia, and also to provide data for calculating the RBC indices. So here is the reference range and also optimal range of the RBC count for both male and female for your review. So with an increase of RBCs count back on your laboratory test, here are some conditions that may contribute to that. First is polycythemia vera. That is a stem cell disorder. Next is secondary polycythemia. Now this type of polycythemia, it develops due to erythropoietic stimulation by certain conditions. And that would be Smoking, chronic arterial hypoxia, could be tumors associated with that, as well as excessive stress. Certainly you want to consider COPD. There could also be significant dehydrations. Some hemoglobinopathies will cause an increase in RBCs, certain medications, and certainly high altitudes. So with a decrease in RBCs, you need to consider blood loss, reduction in production defects of the RBCs, and premature destruction of the RBCs, and I'll be going over that. Various types of anemia can cause a decrease, as you see on the slide. Aplastic anemia, anemia of chronic disease, iron deficiency anemia, megaloblastic, pernicious, sickle cell anemia, thalassemia, malabsorption syndrome such as celiac disease, and also hemolytic anemia. And again, blood loss, you need to consider that as well for a decrease in RBCs. Where is the bleeding? Is it GI tract? It is due to NSAIDs, because that can cause occult bleeding in the GI tract or problems with menstruation. Now, anemia caused by blood loss. So here again, some of the conditions, just to hone in on that, consider gastrointestinal conditions. Ulcers, hemorrhoids can do that. Again, problem with menstruation, prolonged use of certain medications. You need to keep all of these in mind. Next is anemia caused by reduced production or defective RBCs. And I have the conditions listed on the slide for you. Aplastic anemia, anemia of chronic disease, iron deficiency anemia, megaloblastic, pernicious, sickle cell, thalassemia, and again, certain medications and GI conditions. Again, you can have multiple things happening at the same time, so keep that in mind as well. Anemia caused by RBC destruction. You need to consider hemolytic anemia and conditions that would cause premature destruction of the RBCs. Here are some of the symptoms of low RBCs for you to consider. Weakness, fatigue, shortness of breath, pale skin, headaches, heart palpitation, dizziness, mental confusion, and loss of libido. By the way, please take a look at the line of Evexia nutraceuticals. The ones on the slide should be considered after assessing the cause of the low RBC count. And here are some supplements for consideration: Mineral Complex Plus, Multi-Complex Plus, Amino Iron Chelate, and B12 Folate Max. Next is hemoglobin. And as you know, hemoglobin serves as a transporter for oxygen and carbon dioxide. And it contains a heme. And remember, that is that area where iron is surrounded by protoporphyrin and also globulin. Now, abnormalities in globulin structures, they're called hemoglobinopathy. Some examples you're probably familiar with: sickle cell anemia, hemoglobin C disease. And there are some diseases caused by abnormalities in hemoglobin synthesis, such as thalassemias. And by the way, since iron is part of this structure, iron deficiency is considered an abnormality of hemoglobin synthesis. So hemoglobin synthesis is going to start and end in the mitochondria with enzymes located in the cytosol performing the ring forming and decarboxylation steps. Now, the intermediate structures along the pathway are called porphyrinogens. And please remember that heme is acquired at the active sites for oxygen binding, oxygen utilization, and oxygenizing systems, cytochromes, and also mitochondrial electron carriers. In other words, heme is part of the electron transport chain for energy production. In the final phase of metal incorporation, inserts an iron into the protoporphyrin ring to produce heme, and that's what you see in the center. There's some contrast to the right and left of the heme group. Just to look at in nature, chlorophyll, there's a magnesium in the center, and vitamin B12 cobalt in the center. Notice the ring shape, or the protoporphyrin ring shape, throughout the chlorophyll and the heme group and vitamin B12. On this slide has the optimal ranges and reference ranges for male and female hemoglobin values. This slide lists some conditions associated with increased and decreased hemoglobin. I'll go over the increased first. Dehydration, there's smoking, polycythemia vera, high altitude, COPD, emphysema, and congestive heart disease. Conditions that can cause decrease in hemoglobin are anemia, hemoglobinopathy, dietary deficiencies such as iron, B12, B6, folate, copper, and vitamin C, hypothyroidism, certain medications, hemorrhage, renal disease due to reduced erythropoietin, chronic diseases such as rheumatoid arthritis, lupus, and sarcoidosis, digestive disorders, malabsorption, inflammatory bowel disease, irritable bowel syndrome, and finally, bone marrow failure or cancer. Next is the hematocrit, and that is the percentage of RBCs in the blood and provides an indirect measurement of the number of RBCs and the RBC volume. Now on this slide, I have outlined the reference ranges and optimal ranges for male and female, and you'll notice the increase and decrease of the hematocrit is the same as increase and decrease in hemoglobin value. So now it's on to the RBC indices. Now the indices, like I said earlier, are used for classification of anemias. The mean corpuscular volume and the red blood cell distribution width, that's going to give you information about the RBC size. The mean corpuscular hemoglobin will give you information about the average amount of hemoglobin in the RBC, like I said earlier. And the mean corpuscular hemoglobin concentration, that's going to measure the average concentration or percent of hemoglobin in the RBC. Now, the size of the RBC can be further categorized into normocytic, which is a normal state, microcytic being small, and macrocytic being large. And the hemoglobin can also be categorized into normochromic, meaning normal amount of hemoglobin, hypochromic, or hyperchromic, and that would be viewed on the peripheral blood smear. So you need a peripheral blood smear to categorize the cell as normochromic, hypochromic, or hyperchromic. So let's take a closer look at the RBC indices. First is the mean corpuscular volume, and that's generally used to differentiate and diagnose various types of anemias, as I said earlier, and it's the most clinically useful of indices. If the MCV is small, microcytic, meaning small RBCs, there could be a problem with abnormal synthesis of hemoglobin and iron deficiency anemia. And please remember that hyperglycemia can cause macrocytosis due to an increased expansion and involved in osmotic pressure. Below is the formula on how it is calculated. Next is the mean corpuscular hemoglobin. Now that's going to give you the average amount of hemoglobin in a single red blood cell. So individuals with iron deficiency or thalassemia who are unable to synthesize normal amounts of hemoglobin are generally going to have a reduced mean corpuscular hemoglobin, so it should make sense. And on the bottom of the slide, you see how the mean corpuscular hemoglobin is calculated. Next is the mean corpuscular hemoglobin concentration. Again, that's the average percentage of hemoglobin in a single cell. Below is the calculation, and I want you to remember that the iron deficiency is the only anemia in which the MCHE is routinely low, although it can be decreased in other disorders of hemoglobin synthesis. So please keep that in mind. And remember that the MCHE can be falsely elevated in hyperlipidemia, so you need to look at the lipid panel. Next is the red blood cell distribution width, and that's going to give you information about the size. So the RDW is an indication of the variation in RBC size, and it is calculated by laboratory instrumentation using the MCV and the RBC value, and is primarily used to differentiate iron deficiency anemia from thalassemias. And it's important to note that the RDW increases in macrocytic anemias and in early iron deficiency anemia, often before other tests show signs of these kinds of anemia. So definitely need to take a look at that. So on this slide is outlined the reference range and optimal ranges for the MCV, MCHC, MCH, and RDW for your review. So on this slide and the next slide are conditions that increase the indices. So in this slide you see an increase in MCV, conditions that would cause that. Below are conditions that will decrease the MCV value. Over to the right are conditions that will increase the MCHC and conditions that will decrease the MCHC. On this slide are conditions that will increase the MCH and decrease the MCH, and conditions that will increase the red blood cell distribution width. So next is the reticulocyte count and what's known as a reticuloproduction. Start the slide over, please. Next is the reticulocyte count and what's known as the reticulocyte production index, which I'll be reviewing. Remember, the reticulocyte is an immature, non-nucleated red blood cell that contains some ribosomal ribonucleic acid. And this cell is classified under the microscope on a peripheral blood smear after applying a stain. Now, the reticulocyte count is used to determine the production and development of red blood cells as well as bone marrow functions. And under normal conditions, the presence of a few reticulocytes is considered normal. The reason why I want to talk about this analyte is due to the fact that aside from being an essential component of the CBC, it plays a prominent role in initially classifying anemia. So that's why it's important to know about this, this count, the reticulocyte count. Now, the reticulocyte test is generally underutilized. However, it's a pivotal decision-making test when deciding whether the anemia is what's known as hyperprolific or hypoprolific, which I'll be going over in a few minutes. Now, analysis of the reticulocyte count is useful in determining whether or not the bone marrow is responding to the anemia. So when anemia develops, the bone marrow should respond with an increase in the reticulocyte count to help maintain the hemoglobin level. And the absence of that increase reflects the inability of the bone marrow to compensate for the anemia. So that's the information that is providing. Now, the reticulocyte count is calculated as a percentage of the total red blood cell count, so you gotta view it in relationship to the RBC count. For example, in an anemic patient, the reticulocyte count may be falsely elevated due to the low amount of mature red blood cells. So, and I'll show you how to fix that. So, in states of anemia, the reticulocyte percentage is not a true reflection of the reticulocyte production. So, in order to use the reticulocyte count as a measurement of red blood cell production, the count needs to be corrected for both changes in the hematocrit and the effect of the hormone erythropoietin on reticulocyte release from the marrow. And here's the calculation. The first correction involves adjusting the reticulocyte count for the degree of anemia. So here's how it works. When you get the reticulocyte count back, it's right here, they're reported, you'll multiply that times the patient's hematocrit over the normal hematocrit, and then you get the correct value of the reticulocyte count, or reticulocyte percentage. So after using the correction formula, if the count is normal or low in a patient with anemia, that's going to indicate that the marrow response to the anemia by way of production of the RBCs is inadequate and perhaps is contributing to or is the cause of the anemia. Now, on the other end of the spectrum, an elevated reticulocyte count found in patients with a normal hemogram indicates that the increased RBC production is compensating for an ongoing loss of RBCs, most likely due to hemolysis or blood loss. Now, there's another calculation you need to be aware of, and this is in individuals that have significant or severe anemia. And it's the second calculation that needs to be made if the marrow reticulocytes have entered circulation in response to high levels of erythropoietin. Now, the second calculation is on the slide. So you take the corrected reticulocyte percentage, put that over a correction factor, which I'll show you on the next slide, and then you get what's known as the reticulocyte production index, or the RPI. So this slide displays the correction factor. So what you would do is, if the patient's, say, hematocrit came back, let's say between 25 and 34, you would put their corrected reticulocyte count over 2, the number 2, and then do the math from that point. Now, once you do that calculation, here's what it means. If the reticulocyte production index is less than 2, which is also known as hypoprolific, it indicates an inadequate bone marrow response. Now, the reduced bone marrow response can be caused by iron deficiency anemia, B12, folate, chronic disease, aplastic anemia, myeloproliferative disease, radiation, and a host of other conditions. And please keep in mind that the second correction may not be accurate in cases of anemia caused by chronic disease due to the suppression of erythropoietin. That's that hormone produced by the kidneys that stimulates cell production in the bone marrow. Now, on the opposite end of the spectrum, the RPI greater than 2, also known as hyperprolific, suggests that the bone marrow response is responding properly for the degree of anemia. And please keep in mind there are only 3 causes of anemia associated with an RPI greater than 1, and those are listed on the slide: anemia of acute blood loss, hemolysis, and response to treatment. So here's the indications and use of the reticulocyte count. As I said earlier, evaluate erythropoietic activity, in other words, bone marrow response to anemia. It's used to help distinguish between hypoprolific and hyperprolific anemias, to assist with the assessment of blood loss, and to monitor treatment of various anemias. And below is the reference range. Now, here's some conditions that would cause an increase in the reticulocyte count and microscopic bleeding, hemolysis, hemorrhage, in response to treatment of iron deficiency anemia, pernicious anemia, and folic acid deficiency, oxidative stress, heavy metal toxicity, and kidney disease. Conditions that would decrease reticulocyte count in pernicious anemia, folic acid deficiency, iron deficiency anemia, aplastic anemia, adrenocortical hypofunction, anterior pituitary hypofunction, radiation therapy, malignancies, chronic diseases, kidney disease with decreased erythropoietin production, and cirrhosis of the liver. So now it's on to the white blood cell count. And as you know, white blood cells, they help fight infection and they react against foreign bodies or antigens or tissue. Acute and chronic diabetic complications are correlated with an elevated WBC count, so keep that in mind. And an elevated WBC count, even within the normal range, meaning high normal, is associated with both macro and microvascular complications of type 2 diabetes. So you want to get a good look at this if the patient is diabetic or pre-diabetic. Now, higher WBC counts may be associated with the development of retinopathy, albuminuria, which is an indication of kidney problems, and also peripheral vascular disease. And of course, you know the players here, the neutrophils, lymphocytes, monocytes, eosinophils, and basophils, which I'll be reviewing. So, the neutrophils are the most common type. They engulf and destroy infection-causing pathogens. The immature neutrophils are called band cells. The lymphocytes, there's T and B lymphocytes. The B produce antibodies, and the T lymphocytes, they target infected and damaged cells. The monocytes ingest pathogens. The eosinophils, they're found in the bloodstream and also in various tissues. They're associated with allergen and parasitic infection. The basophils, they help kill parasites. They release heparin, histamine, also serotonin. So this slide shows the optimal and reference range for the white blood cell count, and also conditions that would cause an increase in the WBC count, leukocytosis, and a decrease in the WBC count, leukopenia. Now, this table reviews the type of white blood cells, the reference range RR percentage, the optimal range percentage, and the absolute count, and also a description of each type of white blood cell. And as you can see, we'll start with the neutrophils. If you look over at the description, like I mentioned before, primary functions phagocytosis, the immature are called band or stab cells. And as you can see, the absolute count is there. That's when they give a count of the blood cells. The basophils, again, phagocytosis of antigen-antibody complexes. They contain heparin, histamine, and serotonin. The eosinophils are involved in phagocytosis of antigen-antibody complexes. T lymphocytes and B lymphocytes, and I mentioned those, antibody production, and they go after damaged cells. And the monocytes, they help remove debris and microorganisms. And the monocytes, they help remove necrotic debris and pathogenic microorganisms. So I want to get into a little bit more specifics. When you get the differential back, what does all this mean? So let's go white blood cell by white blood cell. So here are the neutrophils of cell type. If the percentages come back increased, that's neutrophilia, these are conditions for you to consider that are outlined in the second column. If it's decreased, these are some of the conditions for you to consider with a decreased percentage. Now remember, it's better to look at the absolute count because a shift in percentages, in other words, if one of the white blood cells go high, the others are going to naturally go low. So I always want you to look at the percentage and the absolute count together because that's extremely important. Now, over on the right, you see this is the absolute count, the threshold. If anything is over 12,000 cells per microliter in the neutrophils, these are conditions for you to consider. If anything is below 1,500 cells per microliter, conditions for you to consider. Next, the basophils, pretty much the same story, increased, decreased, but once again, you need to look at the absolute count to be sure that the increase or decrease isn't due to some increase in one of the other white blood cells. Same here for the eosinophils, increased percentage, decreased percentage, and conditions that could cause an increase in the absolute count or the threshold, what that could mean, high and low. And the lymphocytes, same scenario here, conditions that would cause an increase in the percentage and decrease in percentage and the threshold. In other words, anything over 4,000 cells per UL, conditions that would cause that, and anything under 1,000 cells per UL, conditions that would cause that. Monocytes, same thing. Again, for your review, I'd suggest getting a copy of these slides. They're very, very helpful when you're looking at the CBC. Now, this slide shows some nutraceuticals that can be very, very helpful with a low white blood cell count after you've done your review. So keep that in mind. There's Gastro Plus, Multi-Complex Plus, Essential Fatty Acids, Probiotic Essentials, Zinc Max, and C+ flavonoids. Again, take a look at the lab test and prescribe accordingly. So now it's on to platelets or thrombocytes and the mean platelet volume. I'll be discussing both. Now platelets, as you know, they're non-nucleated. They're these little disc-shaped structures. They're 1 to 5 microns in diameter, and they're formed in the extravascular spaces of the bone marrow from a cell called the megakaryocyte. Now both the liver and the bone produce a hormone called erythropoietin, and that's going to promote the production and maturation of the megakaryocytes to form platelets. So the main role of the platelets, as you know, is to maintain that vascular integrity by forming clots whenever necessary. And like I said earlier, the lifespan of a platelet is about 7 to 10 days, and their function can be affected by many things: medications, certain vitamins, certain foods, spices, systemic conditions, renal conditions, and other hematological conditions. So you need to keep those in mind. Remember that platelets also transport other components of the blood, such as cytokines and neurotransmitters, in particular serotonin. Now this slide shows the reference range and optimal range for the platelet. If the lab tests come back with a low platelet count known as thrombocytopenia, it can be due to two conditions: an immune condition and a non-immune condition. Now, an immune thrombocytopenia usually happens when the immune system mistakenly attacks and destroys the platelets. And this can be triggered by HIV, could be triggered by hepatitis, or actually H. pylori. And in children, it can follow viral infections such as mumps or even the flu. So I want to take a look at the cause of an increase in platelet count, and they're listed on the slide. There could be acute hemorrhage, severe trauma, malignancies. About 50% of patients with unexpected thrombocytosis are found to have malignancies. Keep that in mind. After splenectomy, infection, chronic inflammatory disease, stress, cirrhosis, and magnesium deficiency. Now, conditions that will decrease platelet count, known as thrombocytopenia, mucosal and/cutaneous bleeding, decreased production, increased platelet consumption. In other words, they're being used due to a pre-existing condition. Thyroid dysfunction can cause this, and certain medications. So on most lab tests, you may get back what's known as the MPV, and that is the mean platelet volume. So I want you to think about the NPV to the platelets as the MCV is to the RBCs. And in general, lower platelet counts are common with higher platelet volumes. So that's how that works. And I want you to remember that an elevated MPV with a low platelet count suggests the production of platelets is intact. Now, a normal or lower MPV with a low platelet count suggests a problem with platelet production. So here's the reference and optimal range for the platelet count. It's 7 to 10 centiliters. And I have conditions that would cause an increase in the mean platelet volume and conditions to review for a decrease in the mean platelet volume. This is Dr. Sodano. Thank you so much for listening.
You can reach us during our extended business hours from 8 a.m. to 8 p.m. Eastern Time, Monday through Friday at 888-852-2723, or anytime via email at info@evexiadiagnostics.com. We would love to hear from you and are happy to assist with any needs or questions that you may have. Thank you again for joining us on this very special topic. Until next time, we wish you all the best on your pathway to wellness.